Hello.
Okay, sir. I think we can start now.
Yeah, please start. Please start.
Welcome. Uh, Small introduction, sir. Good evening, everyone, and a very warm welcome to today's surgical case presentation webinar. I am Yalini, State President of Global Association of Indian Medical Students, Tamil Nadu. I will be moderating this session. It's an honor to introduce today's speaker, Dr. Rajamahendran, sir, from the Department of Surgical Gastroenterology, a respected person known for his clinical acumen and teaching excellence. Today's topic is gastric outlet obstruction, a condition that continues to challenge even experienced surgeons due to its diverse etiologies and management complexities. In this session, Dr. Raj Mahendran sir will guide us through comprehensive case, shedding light on the diagnostic approach, surgical decision making, post-operative care involved in managing this condition. Madan Raj, a final year student from Madurai Medical College, will be presenting today's case. Please feel free to note down your questions. We will have a question and answer session at the end. Without further delay, I now invite Dr. Rajamahendran sir to take over and enlighten us with today's session. Sir, over to you.
So, good evening all. Thank you for the session. Thank you, session for. So, just before starting the session, before starting the presentation, let me just give you a brief introduction about the gastric outlet obstruction. After that, we'll start the presentation. So, basically, what is gastric outlet obstruction? You should all know what is gastric outlet obstruction. So, I hope you are seeing my screen there. So, gastric outlet obstruction is an obstruction starting from stomach to duodenum. Okay, that is a obstruction from stomach to duodenum. So, somewhere up to this DJ flexure. So, up to DJ flexure, it may be the obstruction may be in the stomach or it may be in the duodenum. Up to DJ flexure, if there is an obstruction, we call it as gastric outlet obstruction. Okay, so gastric outlet obstruction. Because obstruction beyond this, what is the name for the obstruction beyond this DJ flexure? If there is an obstruction in the jejunum or ileum, if there is an obstruction, we call it as small bowel obstruction. So you know, naturally no small bowel obstruction cannot be kept as an exam case for you. So small bowel obstruction is an emergency, so it will not be kept as an exam case. So the obstruction, what you're going to get is gastric outlet obstruction. So when we are preparing for our final year at the time of 2003, the most common cause of GOO, in our period was peptic ulcer disease due to chronic duodenal ulcer. So chronic duodenal ulcer happening in the first part of duodenum causing peptic ulcer disease is the most common cause of GOO in 2000, around 2000, 1990 to 2000 and all. When we see a patient with gastric outlet obstruction, immediately we will say it is mostly due to peptic ulcer disease. But present scenario is totally different. In 2025, when you get a question on gastric outlet obstruction, even today we operated a case of gastric outlet obstruction due to cancer stomach. So it is usually cancer stomach. So cancer stomach, especially in the pylorus or in the antrum, pylorus or in the antrum will cause a similar obstruction, that is gastric outlet obstruction at this place. So these are the two common causes, and gastric outlet obstruction due to cancer stomach is the most common cause in today's exam on 2025. So today, what about this peptic ulcer disease? Is it still present or not? So let me tell my practical experience. In the past 5 years, I have operated only 3 cases of peptic ulcer with the duodenal ulcer. So it has come down so much because of the pantoprazole and PPA and other drugs which are available in practice. So in exam, you should have a lot of guts to say you are seeing a case of peptic ulcer disease due to chronic duodenal ulcer. You might not get this case in practice today. So this case is more or less obsolete in practice as on date. So please remember the cancer stomach with the GOO is the commonest cause of GOO case you are going to see in practice. But naturally, any examiner will want to compare cancer stomach with the peptic ulcer disease. So all your questions will be going on. Is it a cancer stomach or is it a peptic ulcer? The questions will be going on like this. So therefore, when you are presenting a case of GOO, you should ask history related to cancer, history related to peptic ulcer, because the question will be either to cancer stomach towards peptic ulcer. But I'm telling you, peptic ulcer is never seen in practice causing GOO, but you will get questions on peptic ulcer disease related. Okay, this is a basic thing. So cancer stomach causing GOO is the commonest cause of GOO. Okay, so let us start the presentation. I think Dr. Madan.
Good evening,
yes.
sir.
Dr. Madan. Yeah, good evening, Madan. Please start your presentation.
Yes, sir.
Yeah. So Dr. Madan is presenting a GOO case due to cancer stomach seen in his hospital. So let us see the various Viva related questions here.
Shall I start, sir?
Yes, please start, Madan.
Yes, sir. So good evening, everyone present here. Good evening, sir. So I am Matan Ras, currently studying final year MBBS at Madurai Medical College. Today I am going to present a case of gastric outlet obstruction. So Mr. Singara Velan, a 56-year-old male patient from Dindigul, who is a daily wage worker by occupation, came to the OPD with chief complaints of abdominal pain for 2 months and vomiting for 2 months. History of presenting illness: the patient was apparently normal 2 months back, and he developed abdominal pain for 2 months over the upper abdomen, which is insidious in onset, dull aching type of pain, aggravated after food intake and relieved by vomiting, and not radiating to any other sites. So instead of vomiting for 2 months, it was 3 to 4 episodes per day, and the vomiting was 10 minutes after the food intake, which was non-projectile, non-bilious, non-blood stain, and the vomit contains undigested food particles. So there was also history of yes, sir.
Yeah, there are 2 symptoms only. One is abdominal pain and abdominal pain and vomiting. So related to abdominal pain, you will get a lot of questions in Viva. So is dull aching pain aggravated after food intake? What do you suspect? In which case you have pain aggravated after food intake?
So the most common cause would be gastric ulcer, and it can also be aggravated in gastric outlet obstruction also, in case of cancer stomach causing the obstruction.
The basic point you should know here is pain after eating is seen in gastric peptic ulcers. Gastric peptic ulcers will have pain after eating, and duodenal ulcers will have pain decreased after eating. So why is it so? Why gastric ulcer pain increases after eating and in duodenal ulcer pain decreases after eating? What is the reason? Can you tell me?
Sir, in duodenal ulcer, once the food is entered into the stomach, there is increased acid production to digest the food, so it will cause the
No, in duodenal ulcer, what happens when you take food, you neutralize the acid. So the acid in the stomach gets neutralized with the food. Therefore, if you see duodenal ulcer patients, and especially people who have duodenitis, will keep on eating all the time. So when you keep on eating, you will have pain decrease when you have a duodenal ulcer. That is one of the reason duodenal ulcer patients will be very obese. If you see duodenal ulcer patients, they will be always eating. If when you go to their rooms, if they are in the hostel, those duodenal ulcer people know they will have a lot of snacks in their room. They wake up in the midnight, they will eat bananas or biscuits, something they will be eating all the time. So they will be usually obese because the pain gets reduced by eating. Okay, that is the main reason for duodenal ulcer. Then what happens in gastric ulcer? Why there is pain in a gastric ulcer?
The food particles directly touches the gastric ulcer parts, which aggravates the food.
You're partially correct, but the point is when you eat something, the stomach gets distended. So when there is an ulcer, if you distend the stomach, that will cause more pain. Therefore, they will try to keep their stomach empty. They will keep on vomiting. So they will vomiting. Actually, if it is a cancer stomach, it is unrelated to food. Whether it is with food or without food, they have no pain. Whether related to or without related to food. That is a classical feature of gastric ulcer. What about cancer stomach pain? So your history is more in favoring in the history. for gastric peptic ulcer. What about cancer stomach? Cancer stomach pain will be not related to the food. And pain may be radiating to the where?
Back, sir, if it is
Yes.
present.
Yeah, why it is radiating to back sometimes?
Sir, if it is involving it is due to the pancreatitis or involving the pancreas, it
Very
may
good.
be radiating to the back, sir.
Very good. If it is infiltrating to the pancreas, a gastric cancer, the posterior wall of the stomach is made by pancreas. If a cancer in the antrum can directly infiltrate into the pancreas and cause back pain, radiating pain to the back is characteristically seen. That is what you have mentioned, not radiating, relieved by vomiting. So probably from your history, it is more or less like a gastric ulcer causing GOO. So next slide.
Instead of vomiting, present for past 2 months.
So vomiting for 2 months, is it a short history or long history?
Sir, if you are thinking in terms of carcinoma stomach, the symptoms will be for less than 6 months, sir. If it is a chronic duodenal ulcer, it will be more than 6 months of duration. It will be present.
Yes, very good. If it is a peptic ulcer disease, the history will be long history. Patient will be telling 6 months, more than 6 months, 8 months, 9 months, on and off vomit, and therefore vomiting will be in both the cases it will be non-bilious. Please remember, either it is a peptic ulcer disease or a cancer stomach. In both the cases, it will be non-bilious vomiting only. Okay, that's correct. So we can go on next.
So there is a history of abdominal distension over the upper abdomen for the past 1 month. History of ball rolling movements were present, and there was a history of melena present for the initial 10 days, and it was followed by constipation over the course. There was history of easy fatigability and history of early satiety present, and the significant history of loss of weight was present in the form of 15 kg loss in the past 2 months, and history of loss of appetite was present.
Okay, please wait. History of ball rolling movements. This is a classical feature of
gastric outlet obstruction.
Gastric outlet obstruction. Is it more prominent in peptic ulcer disease or in cancer stomach? Is it more prominent in peptic ulcer disease or cancer stomach? Here you should understand one important point. If it is a peptic ulcer disease, stomach will be distended very big size. So very big size would have been distended. But if it is a cancer stomach, the tumor would have infiltrated the muscles and stomach will not have a massive distension. Therefore, ball rolling movements are more prominent in peptic ulcer disease. Ball rolling movements are very less common in cancer
stomach.
Cancer stomach. Okay. So yearly satiety, what does it mean? History of yearly satiety.
History of early satiety indicates that there is a mass obstructing the entry, sir. So the patient feels full even after small amount of food intake.
No, the point is yearly satiety means the stomach is one of the biggest elastic organ. It is like a balloon. You can inflate. Yeah, you can inflate at least 2 to 3 times. You can inflate the stomach. That much you can eat. You can eat 2 unlimited meals. You can eat that much. It can distend. But what happens in cancer stomach with the linitis type? A linitis type which is infiltrating the stomach muscles, the stomach loses its distensibility. So the stomach will not distend beyond such limit. Therefore, the person who is eating 5 or 6 idli per day will now eat only 1 or 2 idlis. He cannot eat more than 2 idli. That is one of the earliest sign of linitis plastica. One of the earliest sign of linitis plastica is yearly satiety.
Early satiety.
Yes. Next, go on.
There was also history of loss of weight and loss of appetite present.
Okay, that's good. Very good. So loss of weight and loss of appetite is also present. Next.
And the patient also denied histories related to history of hematemesis, heartburn, fever, diarrhea, yellowish discoloration of eyes and urine, no history of breathlessness, chest pain or hemoptysis, no history of bone pain, and no history of headache, altered sensorium, and seizures.
So yes, hematemesis. What are the causes of hematemesis in peptic ulcer? What is the cause of hematemesis in cancer stomach?
Yes, so the most common cause of hematemesis is chronic duodenal ulcer because the complication of chronic duodenal ulcer is upper GI bleeding. So the patient can have hematemesis. So
because of the ulcer infiltrating into which vessel?
The most common vessel involved is left gastric artery in duodenal ulcer.
No, this is for duodenal ulcer. Where does it erode?
In gastroduodenal artery is involved in.
Yeah, yes. You just once again you stop your screen share. I will share my screen. 1 second, you wait. Let me explain you what is happening here. This is very important because you should be very clear with related to bleeding in cancer stomach and peptic ulcer. This is very basic thing. Should not forget. So duodenal ulcer is usually seen on anterior wall as well as posterior wall. There are 2 places where this is a duodenum. first part, duodenum first part, the ulcer can be seen either on the anterior wall or on the posterior wall. Please understand, anterior wall ulcers will go for perforation. This is a very common MCQ. Anterior wall ulcers will go for perforation, and posterior wall ulcers will go and penetrate into one of the vessel going here. What is this vessel? This is gastroduodenal artery. So GDA is a branch of, yes, which branch? Common hepatic artery. Common hepatic artery. Gastroduodenal artery is a branch of common hepatic artery. So a gastroduodenal artery will be running on the posterior wall of D1 like this. If an ulcer in the first part duodenum, especially on the posterior wall, please don't forget this. Posterior wall ulcer, when it is active ulcer, it will go and penetrate into the GDA, and gastroduodenal artery will bleed like anything into the stomach, and patient will come to you with a hematemesis. This is the commonest cause of hematemesis. Overall, the commonest cause of hematemesis even today in practice is duodenal ulcer, active duodenal ulcer. See, active duodenal ulcer is may would have caused hematemesis, and after few months, few years, the patient started taking treatment. This chronic, it becomes a chronic ulcer with a cicatrization and GOO like this. Yes, this is one of the cause. It will slowly become cicatrized and causes GOO like this. And in cancer, what about cancer? Cancer is commonly seen in incisura angularis of antrum. This is a common site of antral cancer. So what vessel is coming here like this? What vessel is coming?
Yes, your screen is not visible.
My screen is not visible. It's visible for me. I'm drawing. It's visible. But I'm seeing in another device also. It is visible. Please check. My screen is visible from another artery, another device. I'm verifying. So it is left gastric artery. It's a left gastric artery will bleed in antral ulcers. No, you are going to start your screen sharing. Just I'm going to stop. So please remember, if it is a gastric cancer or a gastric ulcer, it will bleed from left gastric artery source. If it is a duodenal ulcer, it will bleed from gastroduodenal artery source. Okay. So you can start your screen sharing. I will now stop my share. Yes, you please share your screen now. So bleeding, you share your screen, Madan.
Yes, sir.
Yes. You continue because I want you to be strong in where is the bleeding source. Bleeding source in duodenal ulcer, bleeding source in gastric ulcer, no confusion. Okay. So why you are asking yellowish discoloration of eyes and urine?
Most of the obstructive jaundice can occur in patients of carcinoma head of pancreas and
yes, very good.
Cancer, sir.
Very good. So cancer head of pancreas can cause jaundice as well as GOO. That's a very good answer. Can a cancer stomach cause? Well, let us confine our topic to cancer stomach. When a cancer stomach cause jaundice?
Yes, sir. When it is undergoing metastasis, it can cause jaundice. Sir.
Where is the metastasis? Where the metastasis will go?
It cancer goes to stomach? The porta hepatis.
Very good. Yes, very good. Porta hepatis nodes. Nodes in the hilum. Nodes along the porta hepatis. Those nodes can cause occlusion of the bile duct and can cause obstructive jaundice. That is one of the reasons we are asking the yellowish discoloration. And bone pain is not related to cancer stomach because cancer stomach will not produce bone meds. So you can in fact skip that question. So skip that point. So breathlessness, rarely it can cause lung meds, but bone meds are very rare. I can understand from the last 4 words, yellowish discoloration, breathlessness, you have asked, you wanted to know whether there is any metastasis. Please remember, bone meds will not be there. And brain meds may be there, lung meds may be there. So therefore, that's correct. You can go on next.
The past history, the patient does not have any similar illness in the past and is not a known case of type 2 diabetes mellitus, hypertension, tuberculosis, bronchial asthma, or epilepsy. And there is no history of any chronic drug intake or any history of previous surgeries done. So, history, the patient consumes mixed diet. There is no history of excessive consumption of spicy or preserved food. He's not a smoker. He's not an alcoholic. Bladder and bowel habits are normal, and the sleep pattern is also normal.
Okay.
Family history, no issues. Yes, sir.
Yeah, most of them will be knowing what are the important risk factors in diet: smoking, spicy foods, spirit, salted foods,
salmon,
stored foods, and smoked foods. So 6 yes, you should ask about 6 yes: smoked foods, stored foods, salted foods, spicy foods, smoking, spirit. These 6 are very important environmental risk factor for cancer stomach. So family history. So what family history of mutation runs in families causing cancer stomach?
E-cadherin mutation causing diffuse type of gastric cancer occurs.
Very good. E-cadherin mutation runs in families causing hereditary cancer and what type of cancer it is?
It is a diffuse type of gastric cancer according to Lawrence classification.
Yes, very good. It is a diffuse gastric cancer. And this E cadherin mutation, females might have another cancer also. What cancer? E cadherin rendu cancer varum. There will be two cancers. One is gastric cancer, another is? Yes, very good, Monish. That is lobular cancer. Monish has answered in the chat box. It is lobular cancer. Lobular cancer is seen in lobular cancer of the breast is seen in those patients. So please remember, it is lobular cancer. Okay, lobular cancer of breast is seen. Very good. Yes. Please go on.
To summary, a 56-year-old male patient present with complaints of abdominal pain, vomiting for the past 2 months with upper abdominal distension, ball rolling movements, melena, early satiety, and significant loss of weight and appetite with no other comorbidities is probably a case of gastric outlet obstruction, probably due to malignant etiology. Very
good. That's correct. Absolutely correct. You are mostly suspecting malignancy because of the short history and because will be asking from the history, why do you suspect it is a cancer stomach? They'll be asking this. The question you should answer: old age, short history.
Male patient.
Yes, male patient.
And short duration of history of complaints is present.
Yes.
History of vomiting and ball rolling movements are present.
Okay.
Melena is present there, and significant loss of weight and appetite was also present.
Okay. Let us go on to the examination next.
Yes, sir. So on general examination, the patient was conscious, oriented to time, place, and person. He was ill-built and nourished. Hydration was spare, afebrile, pallor was present, no icterus, cyanosis, clubbing, generalized lymphadenopathy or pedal edema. Vitals, blood pressure 130/80 mm of mercury, measured in the left upper arm in supine posture, pulse 82 per minute, regular in rhythm, normal volume, no specific character, no radial or radiofemoral delay, felt on all accessible peripheral vessels. Respiratory rate was 16 per minute, abdominal thoracic type and regular. So after explaining the patient, explaining the procedure and getting consent from the patient was exposed from neck to the thigh and examined in a well-lit room in supine posture. So on inspection, there is a fullness in epigastric region and all quadrants moves equally with respiration. Umbilicus is in midline, inverted, and visible gastric peristalsis was present, 2 per minute, and the direction was from left to right. And the visible intestinal peristalsis was not seen. No nodules around the umbilicus. Left supraclavicular fossa was free. No scars, sinuses, dilated veins, and visible pulsation over the abdomen. Flanks free, hernial orifices free. So this is a video of visible gastric peristalsis.
Yes. So you can see a very well visible gastric peristalsis you are showing here. Very good. Visible gastric peristalsis and visible intestinal peristalsis. How to differentiate?
So based on the direction, visible gastric peristalsis moves from left to right. Intestinal peristalsis can be any direction. It can be from right to left or left to right, and it can be in step ladder pattern also.
Very good, very good. So visible gastric peristalsis, if it is present, means what does it signify? It signifies the stomach is
distended.
Distended too much. Okay, stomach is distended too much. That is the reason for visible gastric peristalsis. Did you look for visible gastric peristalsis after giving 2 liters of water or without any water?
Without any water, I can able to see here.
So in this patient, actually, when there is no visible gastric peristalsis seen in GOO, you should ask them to take 1 liter of water and observe. So we have to give them 1 liter of water and then observe the visible gastric peristalsis. Because what happens now, this GOO patients, after they vomited, the VGP will not be seen. So such people will give around 1 liter of water to examine for visible gastric peristalsis. So very good. Next.
Yes, sir. So on palpation, there is no warmth, not tender. A mass of 5x7 cm in size in the epigastric region, extending 4 cm right to the midline, 2 cm left to the midline, and 15 cm from pubic symphysis, and 8 cm from the zipisternum was observed, which is globular in shape with well-defined borders and smooth surface and hard in consistency, which moves with respiration. And skin over the mass is normal. On leg raising test, the mass becomes less prominent.
Very good. Yes.
And there is no organomegaly seen, no renal angle tenderness, succussion splash pressure, no other palpable mass seen in the abdomen, and no nodes palpable in the left supraclavicular fossa.
Okay, succussion splash. How will you examine for that?
Sir, succussion splash, we should not give any fluid to the patient, sir. After 2 to 3 hours of solid food intake, we have to check the patient by shaking the abdomen, sir. We can able to hear the sound. It is called succussion splash.
Yes, succussion splash should be done before looking for VGP by giving water. Okay.
Yes,
so
sir.
at least 2 to 3 hours, solid food should not be there, and liquid food should be also avoided for 2 to 3 hours. So better it should be done 3 to 4 hours of nil oral. The patient should undergo. After 3 to 4 hours, you should ask for succussion splash. You should see the succussion splash can be heard even without stethoscope, but you can use with the bell of the stethoscope also. You can hear the succussion splash, but you can hear it like a pot containing water. You hear the sound in the upper abdomen. So that is very important test. So which node is you are mentioning that is not palpable on the left supraclavicular fossa? What is the name of the node?
Virchow's node, sir.
So why Virchow's node? You are specifically asking for a gastric cancer.
Virchow's node is most commonly enlarged in cancer stomach, sir. So I am checking for the enlargement of Virchow's node in the left supraclavicular fossa.
Why it is enlarged? What is the root of enlargement?
Sir, from the cisterna chyli,
Yes.
It goes through the thoracic duct and it drains in the angle between the left jugular vein and the internal jugular vein.
Very good.
So the node present in the left supraclavicular fossa can be enlarged.
Very good. So this is a Virchow's node is a left supraclavicular node. It is not only enlarged in cancer stomach, it is enlarged in any abdominal cancers. Cancer stomach, cancer colon, cancer small bowel, even testicular cancer. All those abdominal malignancies will finally drain in the cisterna chyli, which is in the epigastric region. From cisterna chyli, the entire lymphatics is carried by thoracic duct, which crosses to the left side at T4 level. It crosses to the left side and enters the neck and it joins at the junction of internal jugular vein and subclavian vein. It retrograde spreads the lymphatics into the supraclavicular node. So from there, it spreads to left supraclavicular node as a first node. Left supraclavicular node is a posterior group of node, level 5 node on the left side. Please remember, it is not anterior. It is seen behind the sternocleidomastoid on the posterior group. So if this node is present, it is called as trisear sign, Virchow's node or trisear sign. What is that node spreading to axilla?
Sir, it is called the Irish node, sir.
Yeah, there is no Irish node also palpable, no?
Yes, sir.
Yes, there is no Irish node palpable. Very good. So coming to the previous slide, please go to the previous slide. So in this question, there are so many viva points will be asked. So the swelling moves with respiration. What are the cases where cancer stomach will not move with respiration?
Sir, if it is a linitis plastica, the stomach wall is infiltrated, sir. So we cannot find, sir. Ulcerative type.
Linitis plastica also will move with respiration. There is only one reason if it is not moving with respiration. What is it? The mass is not moving with respiration. The reason is very simple. It infiltrates to one retroperitoneal structure. Which structure? Yes, pancreatic structure.
If it is a pancreas, it will.
Yeah, pancreas infiltration. See, let us confine this discussion only to gastric cancer. So pancreatic cancer, epigastric mass will not move with respiration. We are discussing a cancer stomach which is not moving with respiration because the cancer stomach has already infiltrated into the pancreas and fixed to the pancreas. So it is not moving with respiration. That is one of the important reasons it is not moving with respiration. One point from here, on leg raising test, mass becomes less prominent. What do you want to tell from this?
Sir, if it is the mass in the anterior abdominal wall, on leg raising test, it will become more prominent.
Okay.
If it is in the abdominal structures, it will be less prominent on leg raising.
How will you classify a swelling in the abdomen? 3 types of swelling you get in the abdomen. One is parietal swelling. Number 2,
intraperitoneal.
Number 3,
retroperitoneal.
There are 3 swellings: parietal, intraperitoneal, retroperitoneal. So stomach intraperitoneal structures will move with respiration because they are attached to the diaphragm. So therefore intraperitoneal structures ellame respiration they will move. Whereas retroperitoneal structures like pancreatic infiltration, pancreatic cancer, paraiotic nodes, none of them will move with respiration. Very important point. So that is leg raising test is mainly done to differentiate parietal from intra-abdominal swelling. So parietal swelling becomes more prominent. Example of any parietal swelling becoming more prominent in the epigastric region. Can you tell me one swelling there? Which swelling becomes more prominent in the epigastric region? One hernia. Which
hernia.
Epigastric hernia. Epigastric hernia, not umbilical. Umbilical hernia is below, no. I am asking in the epigastric region, when you put the head lifting test, epigastric hernia of linea alba will become more prominent. Or any lipoma present in the epigastric region will become more prominent. Okay. Yes, they are all very important points you should note. So we'll go on to the next slide.
So on percussion, there is no evidence of free fluid, and impaired resonance was there over the mass, and the liver span was 11 centimeter. On auscultation,
Okay.
normal vowel sounds were heard, and on ausculto scraping, the greater curvature was marked and distended 2 centimeter below the umbilicus. Sir. So the stomach is distended,
Okay.
and external genital is normal, and perectal examination is to be done.
Okay. Now the question is, why can't it be a liver mass? From your palpation, can't it be a liver mass? I am saying this is a liver mass. How do you say this is not a liver mass? Yes. What is the important test from clinical cases? Thus, yes, there is a band of
Impaired resonance present in the stomach region.
mass. That apart from that, there is one more point. No, so you just stop sharing. I will share my screen. Now you see, I'll tell you what is this. This is another important clinical question. See, on an epigastric mass discussion, this question will definitely be asked by the examiner. Okay. Can you tell me what is transpyloric plane? What is transpyloric plane? Yes.
It is at the level of L1 from.
Yes, transpyloric plane. This question will be definitely asked in Viva for an abdominal examination. Is at the level of L1. Please tell me where does it run? It is a plane running midway between suprasternal notch to pubic symphysis. Suprasternal notch and pubic symphysis make a line. Midway at this line is this. Middle of this midway of suprasternal notch to pubic symphysis, the midpoint, you have a transpyloric line running like this. So transpyloric line touches at the level exactly of pyloric canal. Pyloric canal, it will be running like this. So this is a very important plane, transpyloric plane, and this plane is very important because if you draw two lines in these two places, this is mid-clavicular to mid-inguinal point. Mid-clavicular to mid-inguinal point. And you get a transtubercular plane here. Transtubercular plane. So now epigastric mass, your case is a case of epigastric mass. Epigastric mass is like this. Epigastric mass is a mass seen in this region. It is bounded by transpyloric plane below and two mid-clavicular, mid-inguinal point line and xiphisternum. This is a epigastric mass. So I am asking a simple question. In epigastric mass, you told there is a mass of 5 into 6 centimeter in this place. And you percussed this mass. It is resonant, impaired resonant. It is not dull. At the same time, it is having impaired resonance. It is not resonant. It is not dull. It is having impaired resonance. That is an absolute term for a mass arising from a hollow organ. And here, when you continue, this is a liver dullness. So this is a liver dullness present here. Now, if you keep on percussing liver dullness like this, what happens now? Coming towards the stomach, in between this area, you have a band of resonance. So band of resonance is present between the mass and the liver. In the term, you should tell. On percussion, there is a band of resonance present between the mass and the liver is a term explaining you are dealing with a cancer stomach and not dealing with the liver mass extending towards the epigastric region. This is a very important line from clinical examination. Band of resonance is present. Please don't forget this point. So band of resonance is a very important term. So because what are the differential diagnoses of epigastric mass? What are the organs seen here? You will have mass arising from the liver. You have mass arising from the stomach. You have mass arising from the pancreas. So like that, lot of areas you can get a mass entering into the epigastric region. You can see mass arising from the para-aortic nodes. So all these mass can present as an epigastric mass. So as an epigastric mass, since we are dealing with a gastric outlet obstruction, we are discussing more on GOO, okay, due to cancer stomach. So now let me stop my sharing. You continue. This point you should not forget, band of resonance. Okay, it's the most important point. Please share yourself. Yes, what finding will you see in a per rectal examination of cancer stomach?
Sir, we have to check for the Blummer shelf if there is any metastasis present, sir.
Number one, Bloomer's shelf. What is Bloomer's shelf?
This is in the
Yes,
pouch
what
of
is Bloomer? So in pouch of Dowler's in. See, what is Bloomer's shelf? Bloomer's shelf is deposit in the pelvis. Pelvic deposit is a term used for males. In females, we call it as pouch of Dowler's. In females, we have pouch of Dowler's called as recto-uterine pouch. Recto-uterine pouch deposit it's Bloomer's shelf. In males, there is no recto-uterine, no, so any deposit.
Recto-vesical pouch.
Yes, recto-vesical pouches deposit there. So in males or females, what type of spread is Bloomer's shelf? Yes, what are the transcoelomic spreads you have? Can you tell me what are transcoelomic spread? Transcoelomic spread, peritoneal spread of cancer stomach. What are the examples of transcoelomic spread? Number one,
peritoneal spread to the peritoneal, and Krukenberg's tumor can be seen in case of a premenopausal woman.
Yeah, number one, Krukenberg's tumor in females. Krukenberg's tumor in females. Number two, Bloomer's shelf. Number three, once upon a time, they thought Sister Mary Joseph nodule is. Yeah, it was a transcoelomic spread in Munadi Pare books. New books are mentioning Sister Mary Joseph nodule is now mostly due to what spread? Lymphatic spread. Lymphatic spread. They are now mentioning it is a lymphatic spread. Present edition Sabiston says it is due to lymphatic spread. So Krukenberg's tumor is a bilateral ovarian superficial deposit seen in premenopausal woman only due to the follicle rupture during ovulation time. Ovulation apo, the follicles rupture and over that the tumor go and deposit, and when you cut and see inside, the ovary will be normal in females. Krukenberg's tumor not seen in postmenopausal woman. It is seen only in premenopausal woman. That is very important. So Bloomer's shelf, Krukenberg's, and you should look for Sister Mary Joseph nodule. And most important point now, what else you should see in PR? Rectal examination. One is Bloomer's shelf. What else? One more important thing I want.
If there is any bleeding, we have to check.
Yeah, very good. If there is a bleeding or melena, you can see a black stools. Very good. Tanshi, that's correct. So yes, please go on.
Other system examinations are normal.
Okay.
So diagnosis, a case of gastric outlet obstruction, probably due to carcinoma stomach.
Okay. Now you have come to a diagnosis of cancer stomach, probably due to gastric stomach, probably causing a GOO. Now the next important question is, you have a patient in your ward with a GOO. What should you do before going further? I'm not asking anything. What should you do tomorrow itself? Now you have a case.
Yes. Since the patient is having vomiting for the past 2 months, the patient will be in fluid electrolyte imbalance. Sir.
Yes.
So I have to correct the fluid and electrolyte imbalance first, and then I have to do the investigation. Sir.
Yes. What electrolyte imbalance is expected in this patient?
The patient, since he's vomiting HCl, so the patient will have hypochloremic, sir. Hypochloremic metabolic alkalosis will be the initial electrolyte abnormality, sir.
Okay.
So then afterwards, it will be converting into hypokalemic, hyponatremic, and it can further progress into paradoxical aciduria.
Okay, let us explain. Please stop your sharing. I'll share mine. Let me explain you the GOO causing electrolyte, because in GOO case, the only thing as an MBBS graduate we expect is to explain about the electrolyte imbalance and how will you correct electrolyte imbalance. This is the most important thing in a GOO case. So please understand, the patient is vomiting acid. Okay, patient is continuously vomiting because of the cancer here, vomiting acid. So HCl is vomited. So naturally HCl is acid. So patient goes for metabolic alkalosis. Please understand this phenomenon. And there is H plus is also vomited. So metabolic alkalosis and hypochloremia. This is the first two important thing. So naturally in a metabolic alkalosis, we have a compensatory phenomenon by the renal tubules, by the nephrons. What they will do?
They will eliminate the bicarbonate ions.
They will excrete bicarbonate in the urine. So when in a metabolic alkalosis, bicarbonate will be excreted, but bicarbonate will not go alone. It will always take with it
sodium ions.
Sodium bicarbonate. So it's a sodium bicarbonate channel. Sodium also gets excreted. So immediately you will get within few days hyponatremia. So hyponatremia has a protective mechanism in your body. What is that mechanism?
RAS mechanism is activated.
Yes, renin-angiotensin system activated and secretes what? Aldosterone is produced. So naturally, aldosterone is going to conserve sodium, and instead of sodium, it is going to excrete one more
Potassium.
positive. Yes, instead of sodium, potassium fellow will go out. So potassium will go out instead of sodium. So the patient develops hypokalemia. Hypokalemia is very important. We have a lot of problems when there is hypokalemia. Patient can go for cardiac arrhythmias, cardiac failure, and also immediately after few drop of potassium, instead of potassium, calcium will start falling. So there may have hypocalcemia, and tetany also may sometimes happen in extreme cases. And after some time, since potassium, calcium are essential for cardiac function, we will not lose them too much. After some time, hypokalemia, hypocalcemia happens to such extent. After some time, there is no positive ion to go out. So which positive ion will take over?
H plus ions will go on.
K plus போச்சு, calcium போச்சு, கடைசியா யார் போவாங்க?
Hydrogen
H
ion.
plus, yes. H plus himself will go. You know, H plus is an acid. So acid itself is getting excreted. In a case of metabolic alkalosis, it's paradoxical. Metabolic alkalosis, acid should not excrete, but in metabolic alkalosis, acid gets excreted. So therefore, this is called as paradoxical
Aciduria.
Yes, this is paradoxical aciduria. So you will never see patients like this nowadays. These are all once upon a time seen. Paradoxical aciduria, patients will not be so sick in India. Most of them will reach the hospital, and the moment they reach the hospital, we will start resuscitating them with the fluid. What is the fluid of choice?
So we have to give normal saline with injection potassium.
Yes, normal saline is the fluid of choice. Please don't forget. Don't ever say ringer lactate. If you tell ringer lactate, you are in trouble. So ringer lactate is not the fluid of choice. In fact, which is contraindicated is ringer lactate. Why?
The ringer lactate on metabolizing, it will release a bicarbonate ion.
Yes, ringer lactate goes to the liver and it gets metabolized to bicarbonate. Lactate gets metabolized to bicarbonate. Already patient is in metabolic alkalosis. If you give ringer lactate, it will aggravate metabolic alkalosis and patient may die. Please remember, aggravate alkalosis. Therefore, ringer lactate should never be given. You should either give normal saline or you can give dextrose normal saline, but never give ringer lactate. Normal saline is given in your book along with KCl supplementation if needed. If KCl is very bad, you will give KCl. So, but what is the problem? Why should I worry about this electrolyte imbalance? Why I am telling you should immediately treat this? Reason is patient may suddenly die. Patient may suddenly die. Hypokalemia, hypocalcemia.
Cardiac arrest can
happen. Cardiac arrest, arrhythmia, patient may die. That is why we are very serious. So GOO cases, first you should correct the electrolyte imbalance. Then only you should do anything else. Even if you want to do some basic investigations, you should first do serum electrolytes, correct the electrolyte imbalance. Then only you will do whatever you want, you will do next. So you can tell the investigations now. Yes. Yes. What are the other investigations you will do? Yeah, you can share your screen.
Yes, sir.
Yes.
The
So we are going to do the
routine,
routine investigation.
Routine investigation will do the complete hemoglobin, complete hemogram, sir. Total count, differential count, hemoglobin, blood grouping and typing, LFT, blood ureas, blood sugar levels, serum electrolytes, and chest X-ray and ECGs will be taken, sir. And specific investigation, we have to take USG abdomen, CECT abdomen, upper GA endoscopy, and endoscopic ultrasound, and diagnostic laparoscopy can also be done.
Yes, these are the various investigations we do for a cancer stomach. Now, regarding the best investigation to come to a diagnosis, which is best in this?
Sir, in Western countries, endoscopic ultrasound is used as best investigation, sir. But in
the point is,
it is not.
Endoscopic ultrasound, don't tell, because most of you, none of our government medical college hospitals or even private colleges don't have endoscopic ultrasound. So the best investigation which is available in your hospital is always upper GI endoscopy. Upper GI endoscopy is the best. So now, before sending the patient for upper GI endoscopy, what should I do? Upper GI scopy.
I have to put a widebore Riles tube and I have to wash the stomach thoroughly 3 or 4 times before sending to endoscopic ultrasound.
Yes.
Sorry, upper GI endoscopy.
Yes, before sending for endoscopy, you should give thorough abdominal, it's a gastric lavage. It may take even 2 to 3 days. It will not be possible even in 1 day. You have to put a wide bore tube, put saline inside it, take it out. Put saline inside it, take it out. So it may take even 2 days, 3 days for a saline. It should come clear. The way you put inside, it should come clear. Then only you should send the patient for upper GI endoscopy. So upper GI endoscopy, now we are going to discuss. Okay. So please stop your screen sharing. Let me share. So there are so many points you should know from upper GI endoscopy. In an upper GI endoscopy, please remember, in an upper GI endoscopy, after thorough preparation, complete lavage, we are going to put a endoscopy. So upper GI endoscopy, what we use today is a flexible scopy. We are no more using rigid scopy. Flexible scopy is how many centimeter length? It is 100 centimeter length. We are going to pass through the nose by a local lignocaine spray. Sometimes we need sedation. Pass the tube inside. Go inside the narrowed area. So you can, if there is no gastric outlet obstruction in the stomach, you can enter into the D2, D3, you can go up to D4, you can pass. So you can up to D4, you can pass the tube in a normal patient. If there is a duodenal ulcer, you cannot pass beyond the pylorus because of the stricture here. If there is a cancer, you cannot pass beyond this place. So if there is a cancer, you cannot even enter the pyloric antrum causing GOO. If it is a duodenal ulcer, you cannot pass here, but you can pass beyond the pylorus in a duodenal ulcer. So now if it is a duodenal ulcer, what will you do? Duodenal ulcer cicatrization. Will you take biopsy?
Sir, we will not take biopsy from the stomach ulcer, sir. We have to take biopsy from the stomach, sir, to test for H. pylori.
Yes, duodenal ulcer biopsy is not taken. Duodenal ulcer area, you should not go into the duodenum and don't take biopsy from the duodenum. You may cause perforation. So duodenal ulcer biopsy is not taken. If it is a gastric ulcer or a gastric cancer, you should take biopsy. If you see an ulcer, for example, if you are seeing an ulcer in this place, so let us assume this is an ulcer causing GOO. This is an ulcer causing GOO. There is a well prominent ulcer with an obstruction there. I should take, whether it is an ulcer or cancer, we don't know, but I should take biopsy from it. How many biopsy should I take?
I have to take 6 to 8 biopsies, sir.
6 to 8 biopsy should be taken with the biopsy forceps. Yeah, 6 to 8 biopsy tissue you should take, number 1. Number 2, H. pylori testing is always taken along with the biopsy. H. pylori testing is also done. We should take H. pylori and you should do it. What test immediately?
Rapid urease test.
Rapid urease test we can do immediately. The slide is available. We can confirm. So biopsy is taken 6 to 8 and you should take H. pylori testing. And when I am taking the scopy back, I will always do this maneuver. What is this?
U or J maneuver we have to do.
This maneuver, I am turning and seeing the proximal stomach. There may be another growth here or there may be another problem in the OG junction. So this is called as J maneuver or U maneuver. You should do J maneuver or U maneuver and look for the proximal OG junction. Esophagogastric junction, fundus and all should be examined. Now the common Viva question comes for you. On an endoscopy, stomach looks normal. Stomach mucosa normal. Stomach mucosa normal in which all mass lesions in the stomach? There is a problem in the stomach, but mucosa normal. What are they?
Sir, it can be linitis plastica, it can be lymphoma, it can be a gastrointestinal stromal tumor.
Linitis plastica, lymphoma or GIST. In all these cases, stomach mucosa is normal. You should understand very clearly the stomach mucosa is like this. Stomach mucosa will be normal. So GIST arises from muscle layer. So GIST arises from muscle layer. Therefore, it mostly grows outside like this. GIST, lymphoma, both the tumors will be growing outside the lumen, and when you examine on endoscopy, the mucosa will look perfectly smooth and normal unless they get ulcerated into the stomach. If there is no ulceration, the mucosa will be normal in a GIST and lymphoma. Similarly, linitis plastica is an infiltration into the stomach. Therefore, the mucosa will look normal unless it gets ulcerated into the mucosal area. It is linitis means muscularis infiltration. So now the question is, in linitis, there will be an interesting finding on endoscopy. What is it? Linitis, what finding will be there on endoscopy? Though I told you mucosa will be normal. Stomach mucosa normal, but one finding is there in linitis. You cannot. See, in endoscopy, what we do? We push gas inside and we distend the stomach.
It will not expand,
yes.
sir.
Yeah, unable to expand the stomach. In fact, I am unable to expand the stomach. Only when I expand the stomach, I can do a J maneuver. Unless sometimes J maneuver panna mudiyadhu. We cannot even turn. The stomach cannot be distended and sometimes the J maneuver itself will be difficult. The main point is unable to expand the stomach is a finding in linitis plastica. So in linitis plastica, lymphoma, GIST, in all these cases, what investigation is better for biopsy?
I have to take a CECT abdomen. In
this case only you have to go for EUS guided biopsy.
Biopsy.
So in these three cases, EUS guided biopsy is best. But the problem is many centers have no EUS guided biopsy. So we will go for a CT guided biopsy. CT guided biopsy. So sometimes we have to go for a CT guided biopsy in all these cases. Yes, now you told these are the points you should not forget in endoscopy. Endoscopically, what are the points you should not forget? And you told there is a CT scan. Contrast enhanced CT abdomen. What are the findings very important for you in this? What are things you see in CT abdomen?
So first we have to localize the site of the tumor present. Sir.
Yes,
tumor.
Tumor, yes, number one, tumor and its
extension.
Yes, extension you can find out in the stomach. Then what are other things I want to see? So you should always able to tell 5 points at least. When you tell something, you should be able to tell 5 points. In CT abdomen, what are things you see?
If there is any nodal involvement is there in presence. Sir.
Okay, nodal secondaries you can see.
There is any adjacent structure involvement. Sir.
Yes, pancreas infiltration, very important. Pancreas infiltration, colon infiltration, all those things I will see. Then, yes, omental
we will check for
omental deposits, peritoneal secondaries. Then
we can check for Bloomer shelf.
Yes, very good. Liver secondaries, Bloomer shelf. Then in female patient means I can look for
ovarian tumor.
Krukenberg's
tumor.
Sister Mary Joseph nodule also can be noted. Another one is there. What is 10th one? In a CT abdomen, these are all findings I should see. All these findings like pancreas infiltration, omental secondary, peritoneal secondary, liver secondary, Bloomer shelf, Krukenberg, Sister Mary 10th ascites, all these will tell me I cannot
operate the patient.
Inoperability. Ascites. Now, this is a very classical investigation we always do in our hospitals because it is only available in our all hospitals. So we all have CT scan, so we will do CT scan abdomen. So you told in between when presenting, what is the role of diagnostic laparoscopy?
So in diagnostic laparoscopy, we can directly enter into the abdomen and we can see directly the mesh, sir. So we no need to do further investigation, sir.
So diagnostic laparoscopy
you can see the peritoneal mesh.
Yes, done for all cases above T1. This is above T1 means for T2, T3, T4 lesions. We will be discussing the staging later, but just remember T2, T3, T4 case nale, you should do diagnostic laparoscopy. The main advantage of diagnostic laparoscopy over CT. Another. What is the advantage of diagnostic laparoscopy over the CT?
CT is expensive, sir. Diagnostic laparoscopy we can.
Advantage. I'm only asking advantage, not disadvantage. Advantage. See, everything I told you I can find in CT. But then why should I go for a diagnostic laparoscopy? There are two things I can find out extra in this. What are they? Better than CT. Two findings I can see better than CT. What are they? Peritoneal secondaries. CT scan miss small 5 mm secondaries. Less than 5 mm, small secondaries will be missed by CT scan. And ascites fluid can be sent for cytology for malignant cells. Cytology for malignant cells I can do from a diagnostic laparoscopy panni. I can take out the ascitic fluid, even 10 ml fluid is there, I can send it for analysis. Peritoneal secondaries I can test. So peritoneal secondaries also I can see. If by doing diagnostic laparoscopy, whoever I thought to be operable, how many percentage patient becomes inoperable? Line from Bailey law. 30% of the patient who were thought to be operable now becomes
inoperable.
Now becomes inoperable. So now becomes inoperable. This is a very important line from Bailey. If you might have thought, okay, the patient is curable by cancer stomach operation, he is curable. When we go for surgery, before surgery, when you do a diagnostic laparoscopy, 30% of them become inoperable because of peritoneal or ascites secondaries. That's a very important point. Is there a role of PET CT scan? What about PET CT?
We can also take PET CT scans.
Yes.
So if we cannot find
any cancer T2, T3, T4, we should send for PET CT. Yes, PET CT. What is the contrast used? Radionuclide substance used?
F18
PET-CT
Deoxyglucose.
what glucose?
F
18
F18 deoxyglucose.
fluorodeoxyglucose. Okay.
Deoxyglucose.
Fluorodeoxyglucose that we are going to use in cancers. In all cancers, we use 18 fluorodeoxyglucose. The concept is this will be taken up by a fast growing cancer. Fast growing cancer will take up glucose more. So therefore, if I give fluorodeoxyglucose, that will be taken by the cancer, and wherever there are distant mets, even brain mets, lung mets, all distant mets. So PET-CT mainly for distant mets. For distant mets, I can find out distant mets with the help of PET-CT. So that is also now advised as per NCCN guideline. They're advising to do PET-CT also for all the patients. So now fluorodeoxyglucose is the contrast used. Therefore, false positivity can be seen in whom? With the fluorodeoxyglucose, where will you get false positivity? Without cancer, you can see that you can think it is a cancer. Number one. Number two. Number one, TB cases. Number two, uncontrolled diabetic patients. Yes. Uncontrolled diabetes and TB patient, they may get false positive result. So in these two people, you should be very careful in coming to a conclusion on PET-CT scan. So now many of your examiners will tell, I'm telling you this will be the answer from many of the senior examiners. So your patient is already having a gastric outlet obstruction. Understand this line very clearly. Your patient is having gastric outlet obstruction. Anyhow, you are going to do a surgery. What surgery usually you do for a GOO?
Subtotal gastrectomy with a D4.
Yes.
D2
If it is an operable cancer, what will I do?
Subtotal
gastrectomy. Yes. Plus
with the lymph node. D2 lymphadenectomy will do.
Very good. With the D2 lymphadenectomy and what else?
CG anastomosis.
Yes, what reconstruction it is called as?
Billroth 2 reconstruction.
Yes, with Billroth 2. For operable cancers, I will remove the distal stomach like this, and I will bring a jejunum like this, and I will do a Billroth 2 reconstruction. This is a Billroth 2 reconstruction we do. So Billroth 2 is gastrojejunal anastomosis. This is for an operable cancer. On opening, they will always say, in a gastric outlet obstruction patient, when you open, you just open and see. If it is inoperable, what will I do?
I will do a palliative gastrojejunostomy.
Yes, this is what your school of teaching. Okay, this is what your school of teaching for many years. Even when I was doing MBBS, the answer is like this. So when there is a cancer here, I will go for a palliative gastrojejunostomy like this. This is palliative gastrojejunostomy like this. This is what your examiners will tell. In a gastric outlet obstruction, if it is operable, I am going to do a subtotal gastrectomy. Inoperable, I am going to do a palliative. Then why should you do? Why you should do PET-CT எதுக்கு பண்றீங்க வேஸ்டா காசு diagnostic laparoscopy எதுக்கு பண்றீங்கன்னு கேட்பாங்க. What you will tell for that? So your examiners might be expecting, you might tell, sir, no need of PET-CT and diagnostic laparoscopy because anyhow I will be going for either a GJ or a subtotal gastrectomy. Please understand, people are not like that. So present situation, people have good awareness. They will ask you, why don't you find out it is inoperable before itself? Why are you telling it is inoperable after a surgery? Therefore, always I am telling you, you should go for PET-CT and diagnostic laparoscopy in all your cancer patients. All your cancer. That is one reason. Another reason is there. What is there in Bailey and Love? Bailey and Love very clearly says, inoperable patients, palliative GJ is now replaced by what procedure?
Stem cell. We can place a stent. Self-expanding metallic stent.
Yeah, that is the latest procedure. You can put a stent in this place like this. Self-expanding metallic stent called as SEMS can be inserted without surgery because anyhow an inoperable case is going to live for 6 months to 1 year. Unwantedly you are going to do laparotomy, patient will land up in huge trouble. So now SEMS can be inserted for those patients. This is the point. So therefore inoperable cancers, if your examiner asks in a case of GOO, is there any role of DLAP or PET-CT? You should say yes, there is a role. I can go for self-expanding metallic stent or I can go for, yes, what I can go for? I can go for either a self-expanding metallic stent or a palliative GJ. So therefore, now there is a role. Please remember there is a role of diagnostic laparoscopy and PET-CT. So you please share your screen. My one system gone. Yeah, please share your screen now and you can continue.
Sir, after the investigation and confirming the diagnosis, we'll start treatment, sir. Like previously we told, I'll start with IV fluids to collect electrolyte and nutrient balance, and whiteboard nasogastric tube insertion and lavage will be done. Surgical treatment will be subtotal gastrectomy with gastrojejunostomy with the Billroth 2 reconstruction.
Very good.
And D2 lymphadenectomy.
I think with one of another my system, I'm unable to join. Once again. Because I could not see the chats. I'm seeing the chats from another device. So anyhow, the other device is not getting connected. Are you able to hear me clearly?
Yes, sir.
Yes. So that actually this completes the presentation of the cancer sum. Whatever you have did as an extraordinary presentation. So completely you have sketched out all the important Viva questions and you have discussed all the essential concepts needed for the exam. So there will be a lot of questions related to some points. I'll tell you now. There will be some related points like this. So let me explain you those points. So you can now stop sharing your screen. Let me ask the questions related to this topic. When you have presented up to this is more than enough. You have already done an extraordinary job. So you have to be knowing other things, what is there in Bailey and Love related to cancer stomach. So let me explain you what is this D2 lymphadenectomy. So D2 lymphadenectomy is a very important concept now. You should not forget because it was once upon a time PG question. Now they started asking this question for UGs also. Now what is D2 lymphadenectomy? Please understand there are levels of nodes. 1 to 16 in the stomach and around areas. Let me draw the levels of nodes. So this is stomach. So this is right cardiac node, right, level 1. Left cardiac node 2.
Level 2.
Lesser curve node is 3.
S3. Greater curve.
4. This is 5. Infrapyloric 5, 6. This is all called as
level 1 lymph nodes.
They are called as level 1 nodes. These are station 1 to 16. So this is stations 1 to 16. So there are 3 levels of nodes and this is 1 to 6 is called as level 1 nodes. So this is level 1 nodes. Level 2 nodes are along the arteries. So this is a celiac artery. Yes. What is celiac artery? This is left gastric artery. This is
common hepatic
artery. This is splenic artery and this is spleen. Now tell me what are the nodes? What is 7?
Left gastric artery.
Yes, 7 is left gastric artery. 8?
Common hepatic arteries.
Common hepatic artery. 9?
Celiac arteries.
Celiac artery. 10?
Splenic hilum and 11 is splenic artery.
Splenic artery. This is splenic artery. And 12 is
hepatoduodenal.
12 is hepatoduodenal nodes. And it goes on up to 16 is para-aortic nodes. Para-aortic nodes. So when you are doing a gastrectomy, let me show you one of the gastrectomies from my patients. So when you are doing a D2 gastrectomy, you should understand what are the nodes being removed. So you can see from this video.
This is a case of distal gastric cancer. We have done a D2 gastrectomy. And we can see that we have taken all the microfatty tissues in the hepatoduodenal ligament. And you can see that this is the celiac axis. You can see the left gastric vessels is right at its base. And this is common hepatic artery going here and dividing into right and left hepatic artery. And you can also see that we have removed the 11 B nodes, that is the proximal splenic nodes also. And we have also cleared the celiac axis nodes.
Cancer stomach here. This is a case of GOO. Cancer stomach here. And we have entered the lesser sac. When entering the lesser sac, it infiltrated the transverse metal colic vessel. So metal colic vessel is also resected. So that is why this big red is here. And we have lifted it. And there is no pancreas infiltration. So pancreas is fully preserved. You can see pancreas is normal. And we have removed and we have the cutter stump. This is the duodenal muscle part. It's happened here. And you can see here the vessels. So this is a pulsation seen in the common hepatic artery. After giving the branch GDA, this is GDA. After giving the branch, it is called as proper hepatic artery. And this is a bile duct. And you can see posteriorly portal vein there. That is a portal vein. So all the nodes in this area is removed. This is left gastric artery. All the nodes in the left gastric is also removed separately. So completed D2 gastrectomy. We are going. So you should be able to understand what is a D2 gastrectomy. Okay, please don't forget D2 gastrectomy means D1 lymphadenectomy means 1 to 6 nodes plus 7. Yes. D2 means
1 to 12.
1 to 6, 7 to 11 plus 12A. 12A means anterior hepatoduodenal. So D3 is done only in Japan. Japanese only do 1 to 16. All the group of nodes are done D3. So gold standard is what we do in India and China. That is D2.
D2 lymphadenectomy.
Yes, D2 lymphadenectomy is the gold standard lymphadenectomy, which is always must. You should tell this always in exam. So now, related to Billrath 2 reconstruction. What is Billrath 1? Once upon a time, it is no more done. What is Billrath 1? What is Billrath 2?
Gastro-duodenostomy we are doing. So we are directly connecting the duodenum with the stomach.
Yeah, after removing the stomach, we pull the duodenum and anastomosis like this. This is called as gastro-duodenal anastomosis. This is called as Billrath 1.
Billrath 1.
Yeah, this is Billrath 2. Billrath 1 is a tension anastomosis. It can leak. So people stopped doing that, and even myself, all the surgeons now do only Billrath 2 like this. So this is gastrojejunostomy. So we have now done a reconstruction like this. Now, this is a very common MCQ. What are the complications of Billrath 2? What is the most common complication?
The bile reflex can cause, sir, and gastritis can also occur.
Yes, very important is bile reflex. Very good. So this bile reflexing into the stomach is a commonest complication called as bile reflex gastritis. Called as, what is the other name for bile reflex gastritis? Alkaline gastritis. Bile is an alkaline. So alkaline atmosphere the stomach cannot tolerate. Therefore, we call it as alkaline gastritis. It's one of the commonest complication. And when you see the stomach looks like a beefy red mucosa. The stomach looks like a beefy red mucosa. Yeah, this is most common complication. Then what are other complications? This is duodenal stump. If it bursts out, it leaks. What is it? This is short note. What is this complication? Duodenal stump leak eye, it comes out, coming out is bile. What is this? Duodenal stump blowout. This is a very common MCQ. Duodenal stump blowout is a complication of Billrath 2. It usually happens on 4th or 5th post-op day. What comes out from that? What is coming out? It is not food. It is only bile and pancreatic juice. Only bile and pancreatic juice is coming out. Comes out. And therefore, it causes biliary peritonitis. What should I do immediately? What is the immediate treatment in this case? Call the radiologist.
Open up the patient.
No need of surgery. Call the radiologist and put here. What is this I have put now? Pigtail drainage.
Catheter.
Pigtail catheter. Pigtail catheter put on the bile, you should take it out. Pigtail catheter drainage is done. So surgery needed when it is a diffuse peritonitis. Surgery ellarku panna maatom. Surgery needed for diffuse peritonitis. Okay, diffuse peritonitis, not for all. Surgery needed for only diffuse peritonitis, you will go for a surgery laparotomy. Otherwise, just a pigtail catheter drainage is enough for these patients. So this is second complication called as duodenal stump blowout. Any other complication? Tell me. Yes, what are other complications? A lot of complications are there. You should know about post-gastrectomy complications. So when you eat some, for example, let us assume you are eating 2 barota. Immediately this 2 barota, yes, that barota will immediately go to jejunum. And as it goes to jejunum, it will absorb the fluid from the body and causes immediate hypovolemia. That is called as what syndrome?
Early dumping syndrome.
Yes, hypovolemia is called as early dumping, which is seen in how many hours? Within 30 minutes.
30 minutes.
30 minutes you will get hypovolemia. This is characterized by what are the clinical features? Giddiness. Giddiness. After you eat, you'll have giddiness and dehydrated. Because there is a massive fluid shift. Barota is hypertonic. So what happens? There is a massive fluid shift. Yes, massive fluid shift causing this problem. So what should I tell the patient to get relieved of?
We have to take a small frequent meals, sir.
No, that is to prevented by. You're answering for prevented by. I'm asking relieved by. This is a table in Bailey and Love. Please go through Bailey and Love. That is a table. Relieved by lying down. கம்முன்னு படுத்திருந்தா சாணம் சரியாயிடும். சும்மா படுத்துருக்க நேரம். It will be all right within few minutes. So relieved by lying down. So this is yearly dumping. But what happens after 1 to 3 hours? By 1 to 3 hours, this baroda will release sugar. This sugar will stimulate
insulin release.
Insulin that causes
Postprandial reactive hypoglycemia.
Yeah, this is called as a late dumping, called as reactive hypoglycemia. Not reactive. It is a reactive hypoglycemia which happens in 1 to 3 hours. Patient complains of
sweating, palpitation.
Yes,
tremors.
Very good. Sweating, palpitation, and tremors are seen in those patients. Sweating, palpitation, tremors. It is relieved by eating. Eat some more. Eating sugar. Take some more sugar, chocolate, something you should take. That is enough for relieving this. So yearly dumping, late dumping. So don't forget these two concepts: yearly dumping, late dumping. And you told one answer that is a very commonly asked PG question: prevented by. So dumping syndrome prevented by 1, 2, 3, 4. Varama enna pannalam?
Small frequent meals.
Yes, very good. Small frequent meals, then
low carbohydrate foods.
Yes, very good. Low carbohydrate meals.
High fatty and protein diet.
Very good. High protein and fat. Then one more.
Dry foods.
Don't drink water while eating. So you take a dry meals. You should not keep on drinking. Some people always put one mouth water. Like that, you should not drink water. If you drink water, there will be more dumping. So please avoid water while eating. Okay. So this is prevented by small frequent meals, low carbohydrate, high protein, and dry meals. And most importantly, drug of choice is what?
Injection octreotide we have to give.
Yes, injection octreotide. Now you can give long-acting octreotides are available, like lanreotide, pesireotide, like that. Many drugs are there. Long-acting octreotides monthly once you can put for dumping syndrome. This is one cause. See, I am explaining you one essay question. What are the post-gastrectomy complications? In a Billrath 2, bile reflex gastritis, duodenal stump blowout, dumping syndrome. What is the next one?
Nutritional complications can occur. Sir.
Yes, like, very important is nutritional. Most common complication is nutritional. What is the most common? Yes, why there is iron deficiency? Can you tell me why there is iron deficiency? Why there is iron deficiency?
Iron is absorbed in the duodenum.
Very good. Iron is absorbed in duodenum, second part and third part. Since the food is directly going to jejunum, they commonly develop iron deficiency anemia, number 1. Number 2, hypocalcemia. Why? Calcium is also
absorbed there.
Calcium also absorbed in duodenum. Iron is also absorbed in duodenum. So iron deficiency anemia, hypocalcemia for long term causing osteoporosis. And since we have removed distal stomach, what factor is gone?
Intrinsic factor is absent.
Vitamin B12 deficiency. Patient will develop B12 deficiency. So this is another important complication. And there is one more complication which is we need PG level question, that is called as afferent deferent loop. Yes, afferent deferent loop is usually not asked in UG period, but just understand. Very simple. This is a stomach. This is a loop going towards the stomach called as afferent loop. The loop going away from the stomach carrying the food is called as efferent loop. If this loop gets obstructed, this is very common. Afferent loop gets obstructed, it is called as afferent loop syndrome. It is most commonly due to long afferent limb. Neat or romba longer, it will go for kinking and torsion. Kinking and twisting. Sutiko. This will go for obstruction. So when you are going to now take 2 idli, 1, 2 idli. The 2 idli will go like this into the efferent limb. But what is needed for the idli to digest? Bile and pancreatic juice. They will try to come here, but they are not able to come because it is obstructed. So the patient complains of pain and distension in the right hypochondrium. Patient complains of pain plus distension on the right hypochondrium. And he will have severe colicky pain. He will shout of pain. And after 1 or 2 hours, this will give a huge pressure and this will come into the stomach and they will have what? Vomiting.
bilious vomiting will present. Bile reflux
bilious
will present.
bilious vomiting வரும் ஆனா என்ன வராது. What will not happen with no food, because already the food has gone to the jejunum. So bilious vomiting with no food is a characteristic feature of afferent loop obstruction. Afferent loop obstruction will have colicky, pain, distension in the epigastric region, and they will suddenly vomit a huge amount of bile with no food. Whereas an efferent loop syndrome is an emergency. Please understand. இங்க அடைச்சிச்சுன்னா என்ன ஆகும்? பைலும் போகாது, இட்லியும் போகாது. So you will have what vomiting?
Non-bilious vomiting.
இல்ல bilious vomiting தான். Bilious with food.
Food.
The efferent loop obstruction is like a small bowel obstruction. It's an emergency. Emergency theater தள்ளுங்க. Shift him to OT. Emergency case. Whereas afferent loop obstruction is not an emergency. You can wait and watch. Some patients will become all right within few days. You can wait for few days. Afferent loop obstruction, you can do electively, wait and watch, and you can do elective surgery. But efferent loop obstruction, which is carrying the food and bile, it's an emergency. You have to operate immediately. Please don't forget, you have to operate immediately. So don't forget afferent and efferent loop obstruction syndromes. So this is a very important complications of Billroth 2 gastrojejunostomy. So now, in exam, usually they will be asking, what is Borman classification? Can you tell me?
The Borman's classification based on the ulcerative, ulceroproliferative, and proliferative rhinitis plastica type 1, type 2, type 3.
Yeah, it is based on morphology. You should tell like that. It is based on morphology. Type 1, what is this?
Polypoidal growth is present.
Yes, it is polypoidal. Type 2, what is this?
Ulceroproliferative.
Yes, it is cratery form. Volcano மாதிரி இருக்கும். Cratery form. Then what is type 3?
Ulcerative form.
Pure ulcer.
Right.
What is 4?
Rhinitis plastica.
Yes, it is rhinitis. So type 1 polypoidal, type 2 cratery form, type 3 ulcer, type 4 rhinitis plastica. This is Borman's classification. And you all know very well there is another classification called as Lawrence. It is based on microscopy. It is based on microscopy. See, Borman என்றது gross microscopic appearance is Lawrence. In Lawrence, you have two types of cells, which cell which is well differentiated like this. Cancer is well differentiated. Yes. இந்த மாதிரி நல்லா இருந்துச்சுன்னா it is well differentiated as intestinal type. It is called as intestinal type. If the type is looking like this, what is this?
Diffuse type.
What is this type? What is how do the cells look like?
Undifferentiated.
Signatoring.
Mutation.
Yes, signatoring appearance seen in diffuse type. So diffuse type is most common in whom? It is this type of, it is seen in young girls. You won't see these cases more common in India. Young girls with the E-cadherin mutation will develop diffuse gastric cancer. It has worst prognosis. Please remember, it is having worst prognosis. So E-cadherin mutation than diffuse gastric cancer, they have bad prognosis. Whereas intestinal cancer is what we see commonly in practice, most common in old men due to environmental risk factors. All the environmental risk factors, and it is having relatively good prognosis. It is relatively having a good prognosis. So intestinal type is having a relatively good prognosis. Diffuse type has a worst prognosis. So these are all very basic theory questions they'll ask you, and they might ask you, what is early gastric cancer? What is early gastric cancer? Define early gastric cancer. Yes, what is early gastric cancer? Cancer infiltrating mucosa and submucosa with or without nodes. Yes, this is early. So cancer involving mucosa and submucosa with or without nodes is called as early gastric cancer. It is detected by what type of endoscopy? Namur endoscopy. What endoscopy? See, in Bailey and Lau esophagus chapter, there is a very important update called as narrow band endoscopy. அப்படின்னா என்னது? narrow band imaging scopy ன்னு ஒன்று பிக்சர்லாம் இருக்கும் பாருங்க பெய்லியில். So narrow band imaging scopy is a scopy used for screening in which country?
Japan.
Korea and Japan. நம்ம ஊர்ல இந்த scope எல்லாம் கிடையாது. So Korea and Japanல the most common cancer in Korea and Japan is cancer stomach. So they will be doing narrow band imaging scopy for all their patients. So அவங்க என்ன பண்ணுவாங்கன்னா narrow band imaging scopy வச்சு பண்றதுனால since they are doing that scopy for their patients, they pick up early cancers of mucosa and submucosa and they can treat them without any major surgery. What surgery will they do for this? They do EMR, ESD. What are these? Without gastrectomy, they can cure it by endoscopic mucosal resection. And what is ESD? Endoscopic submucosal dissection. These are the surgeries done for this early gastric cancers. Early gastric cancer is usually not a theory, it's not a viva question, but it is a theory question. You might get this early gastric cancer in your short note. They will ask you, what is the staging used, Japanese classification, all those things they'll ask you for theory, but usually they won't ask you early gastric cancer in viva. So that's about the cancer stomach causing GO related topics. If you go on to peptic ulcer causing GOO, it is another 2-hour session. So peptic ulcer also can cause GOO, but I restricted myself only to cancer stomach because this is a commonly kept exam case. In peptic ulcer causing GOO, there is similarly discussion on all the vagus nerve anatomy. There is discussion on the truncal vagotomy, high selective vagotomy, complications of those vagotomies. All those things will go on for another 1.5 to 2 hours session on vagus nerve. So any doubts, if you have, please now post in the doubts. There is problem is one of my system gone, therefore I am unable to see. Yes, very good. Most of you answered very well. Like Anshi has answered chromoendoscopy. Yes, that is another name of narrowband imaging. Yes, most of you answered very well. I think there is another problem is in YouTube there are some questions might be there. I could not see that. I could not see multiple devices for answering your queries. So hope next time they'll have a proper Zoom with all of you joining a Zoom connection. So any doubts you have? If you have any, Madan, do you have any doubts among your friends? So extraordinary presentation, Madan, you have prepared well. So
thank you so much, sir.
So you should take cancer stomach when it comes for the exam. So voluntarily you should go for a GOO case. And a GOO case la fail ane aaga mattinga. You will never fail in a GOO cancer stomach. You might get problem in breast cancer. You may get problem in hernia case, thyroid case. But GOO due to cancer stomach, if you get and you're going to correct the electrolyte imbalance, you're going to tell, I will correct electrolyte imbalance by giving normal saline itself, you are mostly passed. So that is one of the most important pass question. I will immediately correct electrolyte imbalance. And second pass question is I will prepare the patient with a wide bore lavage and I will send for endoscopy. Second pass question. If you are telling these two itself, you are passed. And third pass question is if it is inoperable, I will go for palliative GJ. Operable, I will go for D2 gastrectomy. That is enough. These are the points. It's enough to pass. So these very basic questions you should not forget. So paradoxical acidosis, I told you that I gave the flow chart. It is called as paradoxical acidosis because in metabolic alkalosis patient, acid should not come in the urine. Only bicarbonate should come in the urine. In the flow chart I explained, I told you, in this case, instead of, in a case of metabolic alkalosis, after sodium, potassium, calcium, H plus is coming out. H plus is acid, so it is coming out. That is why it is called as paradoxical aciduria. So PET scan is done for looking out distant metastasis, not for abdominal mets. So what is the, so there are some questions. I'm just answering the questions from this. So Ramita has asked paradoxical acidosis, I just now told. Mohit told what is the purpose of taking PET scan. So PET scan is done to look for distant metastasis because we have done a CT abdomen. I can find out problems in the abdomen, but now I want to know whether the patient is having lung mets or brain mets and all. I want to take a PET CT for a diffuse purpose. So ball rolling movements mean the stomach is having an exaggerated movement. Normally, stomach moves from left to right by a simple peristalsis. You will not know there is a peristalsis happening. But in an obstruction, the peristalsis, the patient himself feels. Patient is telling, sir, I'm having some feeling of ball rolling in my upper abdomen because the peristalsis is very heavy. The muscles become hypertrophied because they are not able to empty the contents. That feeling is called as ball rolling movement. That's what we see on VGP. Yes. Hematemesis in cancer stomach is due to erosion of left gastric artery. So I told you, left gastric artery தான் ஸ்டமக்குக்கு பின்னாடியே இருக்கும். அதுல எரோட் ஆயிடும். That is the main reason for hematemesis. So hematemesis is actually very common with which among the tumors? So this is stomach. So left gastric artery is one of the major supply. Celiac artery left gastric artery the major blood supply of cancer stomach. Sorry, of stomach. Left gastric artery is a major supply. So it will be supplying the major part of the stomach like this. So if there is an ulcer or a cancer in this place, this ulcer will erode into the left gastric artery and it will cause severe bleeding into the stomach. And that is a common. So hematemesis in cancer stomach is usually due to infiltration to left gastric artery infiltration. So duodenal ulcer la na sonnadhu inga duodenal ulcer la vandu if this is a duodenal ulcer it infiltrates into gastroduodenal artery. This is gastroduodenal artery. If it infiltrates into this artery it will bleed into the stomach. That is a GDA. Okay. So hematemesis, please don't forget. Some examiners might tell the bleeding can be from the artery running posterior to stomach like this. So sometimes the stomach can be eroding into the splenic artery also. Splenic artery erosion hematemesis varalam, but commonest is left gastric artery bleeding. Splenic artery also can get eroded because it is running on the posterior wall. But I have not seen a case of splenic artery causing erosion and causing bleeding. Most of the cases which I have seen are all left gastric artery bleeding only. Okay. So any other doubt? I think I'm not seeing any doubts from the chat box. Any more doubts? If you have, please tell me. Or else we'll complete the session and see you on another session. So I'll be uploading many clinical videos in my YouTube channel. You can follow my YouTube channel. So final year clinical cases, previously the cases were all updated based on 27th edition. So I removed them so that you will not get any confusion in the exam. So this is my YouTube channel. I will be uploading all the new videos. I will be uploading new videos will be recorded based on 28th edition Bailey. So I don't want you to make any mistake in the exam based on 27th edition or 26th edition contents. So therefore I removed all those videos. Don't worry, within few months I will finish off all the new videos and I will upload all the new videos. So new videos based on this edition I will upload clinical cases in my channel. You can see all the long cases and short cases will be available in my channel gradually. So I don't want you to go into trouble answering the old videos. Okay. Because in old videos, I myself would have told in this case, diagnostic laparoscopy is not needed in a case of GOO because patient is already having a obstruction. So we'll directly go for laparotomy. But that is removed in New Bailey. They have told very clearly, even if it is a GOO case, go for diagnostic laparoscopy. If it is having a peritoneal mets, go for SIMS. That is a New Bailey update. Okay, that's a New Bailey update. So late dumping. So late dumping syndrome is a condition where the food particles which has gone to the jejunum, the food particles which have gone to the jejunum is now releasing lot of sugar. See, stomach slow up, it will release slowly. But what happened here? The food particles have gone immediately to the jejunum. All the food particles are having lot of glucose. So the glucose is released into the circulation. It stimulates lot of insulin and insulin-like factors, IGF. They are all stimulated in excess amount. And this will go and neutralize the sugar, inhibit the sugar or reduce the sugar. And this rebound effect will cause reactive hypoglycemia. So reactive hypoglycemia, which can be diagnosed on measuring postprandial blood sugar will be less than 60. Less than 60 postprandial pathina. So very less. This is a classical late dumping syndrome. It is due to inhibition of the glucose by the insulin produced in enormous amount. Okay, so all this can be prevented by eating small diet. Okay, don't forget that. Yes. So gastric cancer and peptic ulcer overall points means I tell you, peptic ulcer is a separate chapter. Peptic ulcer is a separate chapter. Peptic ulcer and cancer stomach, there is a big table in our long case book. You can see that. So peptic ulcer disease causing GOO. Cancer stomach causing GOO. So this starts from history. Peptic ulcer is common in young males. Cancer stomach seen in old males. Peptic ulcer disease will have a long duration of symptoms. Cancer stomach will have short duration of symptoms. Peptic ulcer will have classical symptom of weight gain. They'll have weight gain. Due to eating, they'll have a history of weight gain. Now, because of GOO, they would have gone for weight loss. Whereas cancer stomach will be always having weight loss. This last 6 months, they'll be having weight loss. And related to the pain, I told you, pain is decreased after eating in peptic ulcer causing GOO. Whereas here, pain is unrelated to food. Pain is unrelated to food and seen in cancer stomach with GOO. It is unrelated. Here, pain is decreased after eating. Here, pain is unrelated to food. So, peptic ulcer disease is having long duration. Here, it is short duration. And peptic ulcer disease due to GOO, you can, on examination, if you go on, there will be prominent VGP. Prominent visible gastric peristalsis seen. VGP will be, may or may not be seen in CS stomach causing GOO. And most important differentiating point between peptic ulcer and cancer stomach is, you should not forget, if there is a mass palpable, it is cancer stomach. There is no mass palpable, it is peptic ulcer. This is very important. But when there is no mass palpable, it is peptic ulcer. When it is a mass palpable, it is cancer stomach. And in cancer stomach, you will have all features of secondaries. Supraclavicular node, Irish node, Bloomer shelf, Krukenberg tumor, everything you should examine in a cancer stomach. None of them will be seen in these guys. No features of metastasis will be there. So that's the main difference in clinical and examination. But naturally, I'm telling you, there will be, you will never have a case of peptic ulcer due to GOO. It's not seen nowadays. You will always get a case of cancer stomach with GOO with an epigastric mass. And many times nowadays, the examiners, since we are not getting GOO cases, examiners have kept this case as epigastric mass. So epigastric mass is an exam case now. So don't expect GOO in exam. So epigastric mass with or without GOO will be an exam case. So exam case on the GOO because we are not getting a lot of GOO cases. Patients are coming yearly to the hospitals nowadays. So therefore, I was wondering, very good video shown by your colleague there. So your friend has shown very good video. So very good video has shown. So please understand, these are the basic points: peptic ulcer disease and GOO. Peptic ulcer disease, young males; cancer stomach, old males. Peptic ulcer, long duration; cancer stomach, short duration. Peptic ulcer, weight gain; CS stomach, weight loss. And pain decreased after eating in duodenal ulcer. Pain is unrelated to food in cancer stomach. So prominent VGP can be seen in GOO, less prominent VGP in cancer stomach, and no mass, and there is a mass. Mass is a very important catch point. Okay, with all features of secondaries are seen in cancer stomach. So cancer stomach can be kept in exam case as epigastric mass. They may have no GOO also. You might have a case of cancer epigastric mass which is moving with the respiration. That is a classical cancer stomach case nowadays we are getting. In an epigastric mass, you can also have a differential diagnosis. Cancer stomach. You can also tell GIST in the stomach. You can also tell lymphoma of the stomach. Therefore, the discussions will go on into all these topics. So epigastric mass is a definite PG case. PG students' case is epigastric mass. For final years, they may keep an epigastric mass and they'll go into GO. But for PGs, they will go into CA stomach, GIST, lymphoma, pancreatic cancers, everything they will go on. Pancreatic cancer, everything they go on in depth. Okay. So that's about the discussion. Succussion splash is a audible sound we hear. I cannot show how to. You just drink 1 liter of water and you just move yourself. You'll hear a water sound in your stomach. No, that is succussion splash sound. Normally it is heard. Normally it is heard. It is heard in GOO without even drinking water. So normally you can hear succussion splash by drinking 1 liter of water. Okay. Thank you all, friends. Thank you for an interactive session. See you all in another session. So thank you so much.
Thank you so much for giving me this opportunity to present to you, sir. Thank you, sir. And I also thank James for giving me this opportunity.
Thank you. Thank you. Thank you. Thank you for James.
It was a nice interaction with you, sir.
Thank you, Madan. Thank you. All the best. Thank you. Bye.
Thank you,
Thank
sir.
you, sir.
Thank you. Bye. Thank you.